This essay was originally prepared for the 1989 meeting of the American Academy of Restorative Dentistry. The subjects we will cover are transillumination and magnification for the diagnosis of cracks. I'll go through a retrospective study on 5 patients and then speculate about causes and prevention. The photographs were taken back in the 60s, 70s, and 80s. This is typical of the dreaded disaster we hope to never see, because the end result is, of course, the loss of the tooth. Here is a horizontal fracture of an abutment tooth. This is typical fracturing of a cusp due to inadequate restorative design. This is typical of the cracks which propagate from the corner of interproximal restorations. This is a vertical crack which will likely go well below bone level. The most common crack you will see is the mesial distal fracture line under old amalgams or large restorations. This is a rather rare buccal lingual crack in an upper molar. This crack did not extend all the way across the floor. This one is interesting in that it followed the pulp canal all the way to the apex. So now let's discuss transillumination for diagnosis of cracks. This was an excellent transillumination unit that I bought in the late 60s. It had a small diameter wand with variable light intensity. Both are essential requirements for proper diagnosis. Here is a rather unremarkable looking tooth. On closer examination, problems start to become apparent. The differential diagnosis between enamel craze lines and dentinal cracks is that cracks in dentin stop the light transmission. Enamel craze lines do not. This is an example of both. We have a vertical craze line and a horizontal dentin crack. This was a fatal vertical crack as seen through an endodontic access hole, which beautifully demonstrates the light stopping at the interface of the dentinal crack. It is important to vary the angulation of the light and the intensity of the light to better evaluate the extent of light transmission or the lack thereof when you see a crack. This again illustrates the stoppage of light transmission at the crack interface. Another example. During the preparation, this looked like it was cracked at the base of the cusp, but transillumination revealed that it was not. These are the typical enamel craze lines, which are not dangerous in any way. This is a very severe marginal ridge crack. Here we see the dilemma that we face every day. There are cracks over the marginal ridge, both mesially and distally. The distal one transmits just fine, but the mesial one is suspicious. This one requires very careful reevaluation at every subsequent appointment, using various angles and light intensity. Here, lighting from the buccal as well as the lingual is required. Once the pulpal floor has been exposed by preparation, it's then easy to evaluate the extent of the cracks. Dr. Sherilyn Sheets has developed a percussion diagnostic technique which may be better, but I'm told by those who have used it that it's probably too complex for the average office. Now let's discuss the parameters of magnification. Obviously, the better we can see, the better we can perform. Sometimes magnification is described in diopters, which can be very misleading. A diopter is the reciprocal of the focal length measured in meters. So if the lens had a focal length of 1/3 of a meter, the enlargement would be 3 diopters. I used the Designs for Vision magnification equipment, and these are the 3X regular field binoculars. These are the 4.5 wide angle binoculars. This is the view we have without magnification from about 1 foot away. This is 3.5x magnification from the same distance. Again, a normal unaided view. and 4.5x from the same distance. Now let's briefly discuss optics. The brighter the light, the smaller the aperture, the greater the depth of field. This applies to cameras, surgical loops, microscopes, and I think the human eye. This is the formula for the depth of field as derived from a YouTube video. I can't possibly explain it. The important concept is that depth of field is a relative term. There is only one point where the focus from the lens is absolutely precise at the green line. The smaller aperture decreases the angle of light, so it increases the depth of field. We tolerate some degree of unsharpness, which is the boundary of what we think of as acceptable. The convergence angle as determined by the focal distance and the size of the aperture determines the depth of field, which is the acceptable degree of fuzziness. Here we have the same magnification, but the photo on the left had brighter lighting and therefore a smaller aperture, which gave it a greater depth of field. Microscopes have an intense xenon light, which allows for a tiny aperture, which gives them a marvelous depth of field. As mentioned, I think the same phenomenon applies to the human eye. I asked an ophthalmologist if that is true and got a blank stare, but upon reflection he agreed it might be so. With my atrophying eyes, text is certainly sharper in bright light than in low light. Obviously, the degree of magnification also affects the depth of field. Lighting is the other key factor, and it must originate from between the binoculars. Here, Mike is looking through the distal canal of a lower molar, and the spot of light on the table demonstrates that the light does in fact go right straight down through the visual pattern. In other words, the canal is fully illuminated from one end to the other. One member of our study club can wear 6X all day, but for that to be successful, the convergence angle and the interpupillary distance, the whole thing must be absolutely perfect. The way to judge if your binoculars are correctly aligned is to focus on a page of text and then alternate one eye or the other. And if the image jumps, they are not correct. The image should remain exactly the same. Now we will get to the really interesting data. I had the enormous privilege of practicing with my father for many years. He graduated from USC in 1926 and practiced in Colorado Springs all of his life. He was a superb dentist. Working with him was like going to graduate school all day, every day. I joined him in 1955, so the work you will see here was exclusively his for the first 30 years and mine after that. Gold castings when he went to school didn't fit, and he won the Senior Student Gold Foil Award for restoring the margin of a gold crown all 360 degrees around it. He loved to teach and lectured here and abroad. I had 5 patients in 1988 for whom we had been their only dentists. That provided the opportunity to analyze the entire lifetime treatment history of every tooth which eventually sustained a dentinal crack. An assumption in this analysis, rightly or wrongly, is that the dentistry was reasonably well done so that iatrogenicity is not a significant consideration. The photos were taken in the 60s, 70s, and 80s, and for fun we will go back in time with the original slides from this presentation as given in 1988. So let's meet these 5 ladies. Margaret was age 77 in 1988. She started with my dad in 1933 and had 51 restorative procedures in 55 years, 31% on second molars. She cracked 9 teeth. This data ends with 1988, but I continued to see all but one of them for the rest of their lives. The daughter of the one who moved to California stayed in touch with me and said Margaret didn't need any significant dentistry for the remainder of her life. Please understand this data is the lifetime history of every tooth which eventually developed a crack. It is not data on those which did not. So for Margaret, we will consider the history of 9 out of her 16 posterior teeth. The tooth code is circa 1926, so I have added tooth numbers for you up-to-date folks. Number 18 had a DO inlay in 1940. It became a DOB inlay in 1951, and the tooth cracked in 1967, or 27 years after the original restoration. In the photo on the right, that is the onlay which was made in 1967 as of 1988. Not all of the teeth with onlays had a history of a crack. If a tooth required a restoration and was judged to be vulnerable, I did onlays preemptively, so you will also see many restorations which never developed a crack. That DO inlay of my dad's in number 20 lasted her lifetime. Number 31 had an MO inlay in 1933, was redone in 1954, became an MOD in 1962, then needed an amalgam in 64, and the pulp died in 1970. She then had a gold foil in 73 and 3 more amalgams over the years, and finally in 87 I started over, did posts, a base, and a crown. So that tooth cracked 54 years after the original restoration and 17 years after the endodontic procedure. So it had 9 restorative procedures and endo, but happily survived for the remainder of her lifetime. Number 3 had an onlay because of a crack in 1968 as a virgin tooth. I did something wrong, so I had to do it over again in 1978. Margaret was 59 years old when that virgin tooth cracked. Many of these images are mirror images, so right and left can be confusing. Number 13 had a DO amalgam in 1955. The crack was diagnosed in 72, so 17 years after the original amalgam. Number 4 had an MO inlay in 1938 and a DO amalgam in 1955. Cracked in 1978, or 40 years after the original inlay. The inlays in the first premolars and cuspids and the amalgams in the second molars, which my dad did in the 30s and the 40s, served permanently. Number 19 had a DO inlay in 1936. It became a lot larger in 1954, had a gold foil repair in 1970, and cracked in 79. Or 43 years after the first restoration. Number 14 had a DO amalgam in 1961, an MO amalgam in 66, cracked in 1982, or 21 years after the first amalgam. Number 30 required an MOD inlay in 1948. The pulp died in 1969, and we got around to posts and an onlay because of a crack in 1981. Or 33 years after the first inlay, and 12 years after the endodontics. Number 29 had a DO inlay in 1933. Something else was done in 1968. There was a water smudge on the record, and I couldn't read it. And then it cracked in 1982, or 49 years after the original restoration. There's an error on this slide. She only had 2 endodontic procedures. No surgery of any kind. She was a bruxer, required some occlusal correction in 1980. Never used dental floss, used Stimudents and a perioid for oral hygiene. This is Aline. She was 82 years old in 1988. She started with my dad in 1929 and had 49 restorative procedures in 59 years, 26.5% on second molars. Aline cracked 7 teeth. Number 3 cracked as a virgin tooth in 1959. She was 52 years old at the time, so that tooth was still doing fine in 1988, 29 years after the crack diagnosis. Number 2 had an MO amalgam in 1932 and cracked in 1966, 34 years later. I did not get a photograph of that. And number 1 had an MO amalgam in 1941, another amalgam in 1969, and I lost that tooth to a vertical crack in 1986. I did not see it coming. Number 4 had an MO amalgam in 1929. It was redone in 1941, and the tooth cracked in 1975, or 46 years after the first amalgam. And I left the amalgam in as a base, which created that terrible stain under the onlay. Number 5 had a DO inlay in 1931, was redone in 32 for some reason, had a gingival foil in 64, and then cracked in 1976, or 45 years after the first inlay. Number 18 had an inlay in 1956, a margin repair in 1980, and cracked in 1985. Number 31 had an occlusal amalgam in 1937. The pulp died in 1970, and I did an onlay at the time. There was probably a crack, but the record did not say so. This was 33 years after the first amalgam. So she required 1 root canal, 1 extraction, had no periodontal disease, never used floss, used stimulants, and a perioaid. I did my own endodontics using silver points for many years, till I got talked into using gutta percha, and that wasn't any better. I did not get a reasonable photograph of that casting. Now let's meet Betty. She was age 82 in 1988. Started with my dad in 1929 and had 55 procedures in 59 years, 31% on second molars. Betty cracked 12 teeth. Number 29 had an occlusal gold foil in 1929. It cracked in 1964 after 35 years, and then we lost that tooth to a vertical crack in 1971. So you are seeing the pontic of the fixed bridge in that photograph. Number 5 had a DO inlay in 1937, cracked in 1966, or 29 years post-op. Number 15 had an occlusal foil in 1931, another foil in 1940, another foil in 1949, and cracked in 1973, or 42 years after the first gold foil. Number 12 required a DO inlay in 1946. It cracked in 1977, or 31 years later. Number 13 had a DO inlay in 1949. Cracked in 1977, or 28 years later. Number 19 had a gingival foil in 1929 and then cracked as essentially a virgin tooth in 1977. She was 71 years old at that time. Number 2 had an occlusal inlay in 1931 and cracked in 1977, or 46 years post-op. Number 3 had an occlusal foil in 1931, an MOL inlay in 1958, cracked in 1977, 46 years after the first foil, and then the pulp died in 1980. What you see there is a platinized gold foil repair of the endo-access hole. Platinized gold foil is much harder than regular pure gold, so is more suitable for the occlusal surface. Number 14 had an occlusal foil in 31, an MO inlay in 49, was remade in 1960, and the tooth cracked in 1978, or 47 years after the first foil. Number 18 had an occlusal foil in 29, was redone in 32, which is strange, I don't understand that. A DO inlay in 1946, became an MOD in 58. The pulp died in 1986, and we did the onlay at that time because of a crack, 57 years after the first foil. Number 20 had an occlusal gold foil in 1932, cracked in 1987, 55 years later. We're in the process of making the onlay when this photograph was taken. Number 31 had an occlusal inlay in 1931, a gingival inlay in 1958, The Pope died in 75, and she refused an onlay at that time, so we lost the tooth to a vertical crack in 1985, or 54 years after the first inlay. So this patient had 4 endodontic procedures, some periodontal disease in 1968 was treated then. She routinely used floss, refused to use stimulants and a perioid, and was a heavy bruxer. She was kind of a mean old bag, and maybe that's why she cracked so many teeth, and why her husband Charlie frequently visited the widow, Mrs. Davidson. I would see his car parked in the widow's driveway. Sometimes we know more about our patients than we should. By the way, Charlie didn't crack any teeth. This is Ruth. She was age 92 in 1988, and her telephone number in her first record was Maine 79. She started my dad in 1929 and had 56 restorative procedures in 59 years, 21% on her second molars. Ruth cracked 2 teeth, and number 18 after 32 years with an occlusal amalgam, and number 5 after 33 years with an MOD amalgam. I was not able to get her back for final photographs. She was a wonderful little 4'11" lady, happy and cheerful, great to be around. This is a porcelain inlay which was made in the 40s. In those days you had to adapt a platinum matrix and then fire some porcelain which would shrink, and then you'd readapt the matrix, add more porcelain, back and forth until you got something that almost fit, and then it had to be cemented with silicate which tended to wash out. Nevertheless, this lasted about 50 years. This is Florence, who was age 85 in 1988. She started with my dad in 1925, had 28 procedures in 63 years, 14% on second molars. You will notice that 25 is a year before my dad graduated, and this worked because my grandfather was also a dentist, so Pop had an office in which he could see his sweetheart. They were married right after his graduation, so Mom cracked 4 teeth. Number 3 had an occlusal foil in 1932, an OL foil in 38, and cracked 45 years later in 1977. Number 30 cracked as a virgin tooth in 1977. She was 74 years old at that time. Pop did occlusal inlays for numbers 19 and 18 in 1936. And 19 cracked after 33 years, and 18 after 41 years. The inlays and foils in the upper left quadrant lasted her lifetime, which was 98 3/4 years. Realize that there was no accurate elastic impression material until Andy Sears introduced hydrocolloid in 1937. Wax patterns were carved directly on the tooth. There was one of my dad's records where he remade an inlay 13 times before he got one that actually fit the tooth. And the total fee, including the gold, was $4. So take time to appreciate our modern technology. It is so much easier today to provide excellence than back when dentistry was really hard work. So in summary, there were 5 patients. They had 292 years of dental history. They required 239 procedures, or less than 1 a year. And they cracked 34 teeth, which is 44% of their posterior teeth. 3 were lost to vertical cracks, so I had a failure rate of 8.8%. Not proud of that. But the teeth were restored an average of 36 years prior to the diagnosis of a crack. 1 tooth had both amalgam and inlays. 8 teeth had amalgams only. 4 had just gold foils. 17 had just inlays. There were some that had both foil and inlay. And 4 were virgin teeth. 2 lower first molars and 2 were upper first molars. The distribution of the cracks was 8 lower second molars, 8 upper premolars, 6 upper first molars, 5 lower first molars, 4 upper second molars, and 3 lower premolars. It's of interest that none of them lost a tooth to periodontal disease and only one used floss. We pushed stimulants and perioids for tissue maintenance. We tried to have patients understand that dental disease is voluntary, because it mostly is. Now let's discuss causes, which are certainly multifactorial. Anything we do that alters the integrity of the crown weakens it structurally. The latest technique which the endodontists are doing with separate occlusal openings for each canal is a big step forward. Malocclusion with parafunction likely contributes because lateral contacts on posterior teeth produce bending and shearing forces. The mechanical engineering of our stomatognathic system is of interest from the point of view of fulcrums and lever systems. The worst lever system is a Class 1 from our point of view. Class 3 is the least efficient from an applied force point of view. In these diagrams, P is the power or the muscles, F is the fulcrum, either the joint or a tooth, W is where the work is accomplished, in other words, where the chewing takes place. The human jaw is almost always a Class 3 system. As the contact between teeth moves closer to the muscles, greater force is applied to those teeth with the same muscular effort. Maybe this is why molars are more vulnerable than premolars. Now, we all think we understand everything there is to know about mandibular movement, the kinesiology of the system, right? I'll share a little knowledge challenge with you just to keep you humble. This is Jay. He had been a patient in my practice for about 10 years when one day he asked, "Do you want to see my party trick?" That can be a little scary, but I took the bait and agreed, and this is what he did. Okay, now do your thing, Jay. Notice that there is no lateral or protrusive movement, none. And then go back to the other side again. Yeah, do it again. You are seeing a pure unilateral voluntary distraction of the TMJ. So can you figure out how he does it? I'll give you a hint. All of the muscles below the mandible are quiet. There is no contraction of the supra or infrahyoid musculature. We made a clutch for him which allowed us to attach a face bow to the lower teeth without covering the occlusal surfaces, located the hinge axis, and watched the exact pattern of movement with a face bow. It is straight up and down, not along the protrusive pathway of the eminence. Okay, now do your thing, Jay. I'll run it again. Watch very closely. And then go back to the other side again. Yeah, do it again. Fascinating, isn't it? Jay somehow learned to contract the masseter on one side without contraction of the internal pterygoid on that same side or any of the closure muscles on the other side. He thus uses the lower buccal cusps in their opposing fossae as the fulcrum and rotates the opposite side away from the eminence as a Class 1 lever fulcrum. Unfortunately, about 6 months ago, his endodontist sent me this news about Jay. He sustained a horizontal root fracture of the distal buccal root of the distal abutment for his partial denture. I think his party days are over, because when he distracts the joint on his right side, he was using that molar as the fulcrum, and that is a Class 1 lever. Thermal cycling is a possible cause of cracks. Chewing ice has long been blamed for cracking teeth. One suddenly cools the enamel surface from 96 to 30 degrees and applies a lot of force. Could be true. IATROGENIC kinetic energy may be a contributor. Rex Ingraham, who taught at USC, was studying the efficiency of diamonds for enamel reduction when that was a new technique. He had slides of the interface between the diamond and the enamel, and it was red hot. Too much pressure on the rotary instrument, such as the 30-second crown prep, can cook the surface. Lower molar lingual cusps are vulnerable if allowed to be in a working stroke function. Upper premolars may be anatomically vulnerable for the same reason. It may be that teeth get more brittle with increasing age. Amalgam restorations with wide preps, especially if moisture contaminated, may be a contributor. Maybe composites that oppose the opposite stamp cusp can produce a problem because wear with subsequent eruption produces lateral interferences. Porcelain, when the glaze is broken, also promotes eruption of the opposer. Engineering error as embodied in poor preparation design is a big contributor. Miles Markley in Denver taught minimum prep design for amalgams starting in the 1940s. This is a photograph of Dr. Markley's of amalgams which he placed in 1947 when he was crusading for more conservative cavity design. So 69 years ago, conservation of tooth structure was recognized as important. This is another example of engineering error where the amalgam failed because the interproximal grooves were not placed correctly. They are required to hold the box portion because the isthmus is not strong enough by itself. Jim Summit at the University of Texas did a wonderful 2-DVD series for us promoting minimal occlusal and interproximal cavity design. This video is available on the Restorative Academy's website. The best possible materials for the longest possible longevity is still important. In my era, as you could see, gold was and still is the material of choice. Unfortunately, the in-office milling machines and the economic necessity of paying for them now dictates the treatment plan and preparation design. These modern crowns are almost completely dependent on the luting agent for retention because they have no resistance form. That is the opposite of what we tried to do for gold restorations. In his CRA newsletter, Gordon Christensen has a recent report about how these milled crowns are starting to fail. Manufacturing error can also contribute. These are paraposts circa 1988. In the manufacturer, I think they cut the thread, mill the vent, stamp the head, and then cut the rod to length. Unfortunately, the cutting process burnishes the metal over the vent. Here you see the end view as manufactured on the right, and on the left after cutting the vent open again. On the right is as manufactured. On the left is after reopening the vent with a sharpened disc. All posts, whether cast or manufactured, should have an open vent of some kind, either with an oversized hole or the standard vent. Current paraposts are serrated, which apparently acts as a venting system. Otherwise, it is a hydraulic piston specifically designed to crack the root. Be sure to test by using the bounce back technique. When you press the post in gently, if it bounces back, the vent is not working. Of course, the viscosity luting agent has a lot to do with the necessity for a vent, but there is no point in taking a risk. Vent everything. Relative to prevention, this is my own bias and of course is complete speculation. Initial restorative dentistry as conservative as possible. This would apply to any procedure where we cut tooth structure. Always, always the least amount of destruction to avoid weakening the strength of the tooth. Preserve as much of the structural integrity of that crown as possible. Entrapment of the occlusal surface prevents wedging forces, so I felt it made sense to do onlays most of the time. There was a lecture recently concerning the effort to achieve 5 and 10-year survival rates from zirconia, lithium disilicate, resin nanoceramics, and hybrid ceramics. We already know how to do 5 times better than that. This doesn't make any sense to me. Is white that important? The early diagnosis of dentin cracks is the key to the whole thing, and that requires magnification and translumination and semi-annual exam emphasis. Anterior guidance with posterior disclusion has long been considered to be proper occlusal mechanics to prevent lateral bruxing forces on posterior teeth. I have added breathing disorders to this to acknowledge the huge body of information currently being developed concerning the relationships between TMD and airway dysfunction. Bruxism appears to be correlated with cortisol overload from the stress of oxygen deprivation. Current thinking along these lines may drastically change treatment options in the near future. In defense of gold, you saw the smiles of these ladies. They were very much a part of what one could call the high society of Colorado Springs. White stuff in their posterior teeth was not necessary. They were perfectly satisfied with their appearance. If their restorations had been ceramics of some type, with shorter survival rates than gold, their dental histories and their pocketbooks might have been significantly less favorable. I also want to make the point about their oral hygiene. We made a huge effort to get patients to avoid having to come see us. This was primarily through the use of a perioid or stimulants. Toothpicks, not floss, are the key to gingival health. I tried to get them to brush until their teeth were clean and then use toothpaste after that for the fluoride dose, but with minimal time spent brushing with the abrasives. Compliance with that trick was not really very good with many patients, but at least they got the idea. Again, the proper use of toothpicks, preferably in a perioid, is the key to long-term periodontal health. I'm certain you modern dentists are horrified at what you've just seen, perhaps partly because of today's assumption that everybody wants to look like a UCLA cheerleader with chiclet teeth. But ask yourself if all the teeth with full crowns from day one will survive a lifetime. I don't think so. In war we count body bags. In dentistry we should count dental tubule amputations. Full crowns are the maximum insult. I would suggest that even today, conservative treatment options deserve more emphasis. In conclusion, the data suggests that there is no one glaring cause or material that is the major contributing factor to cracks in teeth. Cracked teeth happen regardless, but there are lots and lots of ways to make the problem worse.